I'd like to welcome Brad Vandersall, and you're from the EDR department.
That's correct.
And I know you're from a different hat, so Safe Patient Handling, but you're also a resource for...
Safe Patient Handling, Behavioral Health Resources. I'm on the Falls Committee. I wear many hats.
The hat he's wearing today
Behavioral Health
is to discuss aggression and violence. And Jen Murray had an incident in the trauma bay, but not the first or last, very aggressive patients in the trauma bay. And Brad's here to give us some tips on how to deal with those situations.
Let me introduce myself. So, as Juana said, I've worn many hats, but prior to becoming a nurse educator with the education department, I was the nurse manager of the Child and Adolescent Psychiatric Program that UCSD we ran that program for about 17 years. And in that 17 years, as a manager, I was an educator, father, you name it. Great job. But most of my career has been in behavioral health. 35 years I've done adults, geriatrics, and drug and alcohol rehab. So that's my main expertise area. But now I'm branching off into other areas. But today we're going to talk about disruptive and aggressive behavior. And Juana asked me to come here. She said mainly because there had been some incidents, but she thought it might be helpful for people to kind of have an overview of how to manage disruptive and aggressive people. So before we get started, anybody just kind of give me an overview, just somebody shout out what you want to get out of this today, because that helps me kind of guide my discussion. Any thoughts on what you want to get out of this class? Just looking at the title, what do you think you want to learn?
What our resources are.
What your resources are? Okay. I can probably help you with that.
How to keep them calm and do what we want them to do.
Okay. The magic one.
The magic.
Anybody else?
The legal ramifications of forcing, physically controlling a patient, can they just leave, let them leave, that sort of thing, when you can hold them down and force them to stay, that sort of thing.
Well, I can answer that right away. Legally, a person, you can't force them to do anything unless they're on a 5150, a danger to themselves or others. That's all.
The doctors a lot of times say, well, he's intoxicated, so you force him, you restrain him. I don't know, but that's my...
You can write it. The doctor can do that and say, I'm going to write a 5150. That's fine.
But they don't.
Okay. Well, that's a different issue. If a physician won't write a 5150, if he thinks he's a danger to himself and others, then he needs to just do that. If he won't do that, then he's in legal trouble. Okay. So, what else do you want to get out of this? Go ahead.
I was just going back to what she said. A lot of the times the doctors will say, they're drunk, they're intoxicated, they can't make a decision for themselves, therefore they have no right to replicate them. They have to stay. That's owned out. Legally, what?
Yeah, I think that's a whole nother topic, ethics and legal. But I understand that the dilemma that you're forced into. But this is not really a discussion on legal aspects.
So next time we'll have risk.
Yeah, we can get. I mean, that's a discussion that probably needs to happen. Okay. Anything else?
Keeping everybody safe.
All right, that's good, because that's how we're going to end today. All right, so I got agenda objectives. We're going to first talk about threat identification. What is dangerous? What do they do that makes things dangerous? What does aggressive behavior look like? Then we're going to talk a little bit about the probable causes of violent behavior in adults. Then I wanted to kind of discuss a self-assessment of what happens when you're threatened with violence. What happens to you personally, and how can you control that to have things come out safer and a better outcome. We'll touch briefly on the principles and mechanics of crisis communication. What language, how do we talk to patients that are in a crisis or a behavioral emergency to make things calmer, not more stressful. And then planning for safe outcomes, we'll end up with that, is what can we do as a team to plan ahead of time to help when What can we do to help keep patients safe? Okay. So what does aggressive behavior look like? Anybody got any ideas? What's aggression look like?
I know what it sounds like.
Sounds like words. Words are easy to identify. I'm going to kick your ass. I'm going to hurt you. But a lot of those things that give us cues about aggression come up. They happen beforehand. They're visual cues. They're things that increase in level of agitation.
Tense body.
Shifty eyes? Shifty eyes? He's got shifty eyes.
A lot of times they'll have that, they'll just like stare and you can see they're just like.
Yeah, that's a good point. There's actually a tool that when I do a longer course, if you're interested in that, it's in development that we'll talk about. Breakdown, staring, tone of voice, anxiety is actually an acronym for it, but we're not going to deep into that today. But so this is kind of aggressive. Women can be aggressive, can't they? The first person I was ever struck by was a woman. In my career, she was very, very intoxicated, and I didn't see it coming. Men can also be aggressive. As a matter of fact, men are more likely to be aggressive than women. Children can be aggressive. Hey, his parents are very proud. He's from Boston. We experience aggression on a daily basis, most of us, and it looks something like this. Road rage. Every day on the freeway you see somebody that just makes you living. At least I do. All right, threat identification. So there's a difference between dangerous and irritating behavior. Anybody does that make sense to you? People can be very, very irritating and push our level of anxiety up to the point that we might see something that's dangerous when it's really just really irritating behavior. Dangerous behavior is threats to hit, punch, kick, bite, scratch, or attempts to do that. Well, if spitting has blood in it, yes. So, I'm sorry, what?
I don't want to.
No, nobody does. It's kind of vile. It's on that borderline. Is it aggressive? So if we have a patient that we know is spitting, we need to protect ourselves. And that way the threat level is less. So when you assess the situation and you have a person that is verbally upset and getting louder and louder, you have to identify what's happening. If I do nothing, is someone going to get hurt? And if you make that judgment, then it kind of clicks into what you were talking about, resources. When we have someone that we think is dangerous and going to hurt us, what do?
Back up.
Well, first of all, we get away, but we have resources. We activate resources, the security to come in and help assist and manage that person. That's the resources you're talking about. I don't expect nurses and doctors to contain patients unless it's absolutely necessary. But resources for security, when you feel threatened, activate that resource. Call it code gray. Are others in danger? Patients, visitors, and staff. That's actually something to really keep in mind when you see this person. Is if he's just in a room by himself and just yelling out loud, we can tolerate that for a while. But if he's in the visiting room and there's other visitors and patients and staff around, then it becomes, if he's threatening others, it's more likely that we need to intervene sooner rather than later. Does it make sense? And then we go right to, if you need help, get it. And make sure someone's calling. Don't just assume somebody called code gray. Make sure that physically that happens. Make sure that you have help coming. Because there's nothing worse than standing there. Because when these situations happen, time is going to slow down. Minutes are going to seem like hours when it's really a crisis. And so if you're waiting and waiting and they're not coming, it's even worse. So prioritize. Err on the side of caution. if activate a code, even if you're not sure, if you feel unsafe and there's other people you feel are in danger, get some help coming. And if they get there and everything's fine, and the guy, the person's upset, why'd you call security? I'm fine, no worries. You know what? You can smooth that out. But if you don't have help and he does assault people, then you like I said, hurt feelings heal faster than bones. It's just something I came up with. Because it does happen. I read reports on security response and restraints, and people get upset when you call security. But it calms them down. But that's something you can talk through. You can't talk through somebody beating the hell out of you in the room. All right. Probable cause or causes of violence in adults. Needs are constant. So when a person's in crisis and they seem like they're going to act out in a violent manner, they haven't been able to get their needs met any other way. So they want something, they feel they need something. And researchers show consistently when people debrief after assaultive incidences, the number one thing was that patient needed something. They needed pain medication. They needed a drink of water. They needed somebody just to talk to them. They need to feel wanted. So when I talk about needs and perceptions, it's all about perceptions. So if I'm the person that's assaultive and I'm aggressive, I don't care about your needs. I only care about me. And I think that's hard for us to remember when we're talking to this person, because we have so many priorities going on, and we want to solve problems, and we want to control the situation. We want to get our shit done, right? We want to get things done. And what we don't realize is that the only thing that's important to this person is his needs and what he wants. And it's kind of, if you flip that and go, let's see if we can just really quick, let's see if we can meet this guy's needs, get him calmed down, get the situation under control. So what need is being threatened? I want you remember, everybody have a good concept of Maslow's hierarchy of needs: safety, survival, safety, security, belonging, love, self-actualization. So when we talk about people in crisis, they're at that very bottom base level of survival and safety and security. You don't get an aggressive person responding from higher level needs. It's always safety, security, survival is what makes a person act aggressive. So if you take that away, I'll have nothing. When I say that, what do you think? What am I talking about? If I take this away from this person, what's the number one thing that makes them lose it? Exactly. If I take this person's control away, if I put them in a situation where they don't know what's going on, they're in a situation that maybe they just woke up and they don't know what's going on, and you start doing things to them, you're taking control of their body. That's what freaks them out. You're taking control, and I don't know why. Some other causes of violence in adults. Previous history of violence and assault. That's always an indicator. Males, older males over the age of 60.
Why the older?
Well, as men age, men number one because they're more aggressive. Age as more and more as we age, there's more and more dementia and confusion. So the higher you go above 62, the more risk there is of dementia and delirium in adults. And dementia is another factor that leads to violence.
What about drugs and alcohol?
That's frequently intoxicated. Absolutely. Anybody think anything else? You guys are experts sometimes too on violence. Drugs and alcohol. Pain. Sometimes severe pain can make a person violent. Thoughts? Comments? All right. Personal awareness. So when I talk about personal awareness, when you're in a situation, has anybody in the room been assaulted on the job? Okay. Me too. I have been. I mean physically assaulted. Yes? Okay. then I'm in the right spot. How does it feel like when you're physically threatened or assaulted? What's it feel like?
Get angry.
You get angry? You want to punch him? Don't do that.
Punch him down.
Your body does something when you get threatened with violence. What is it? Fight or flight. Exactly. Can you control fight or flight? Is it something that... No. It happens. It happens every time. I worked behavioral health for 35 years. Every time someone threatened me, my body started dumping adrenaline into my muscles and my arms and my breathing. You can't stop it, but you can. Once it happens, is when you have to start regulating. Catch your breath. Slow down your thoughts. Think about what's going on. Remember where you are. You're a professional. You're helping this person. So you can't deny. You can't stop the fight or flight from hitting your body, but you can control the symptoms of what it does. What's it doing to my body? It's making me crazy. Yes.
My reaction is quite different if it's a patient that's kind of just like going crazy, just acting out, versus somebody and I feel doesn't know what they're doing, versus if I feel like the patient is intentionally maybe. Yeah, I mean, we deal with both of those kinds.
Right.
So my reaction, I don't really have that big fight or flight if it's like somebody's, I mean, I want to protect myself. But it's a very different reaction if I feel like somebody's intentionally, personally assaulting.
Right. So what you're saying is, when you're threatened, it depends on what the situation is.
Yeah.
What I'm saying is, that's good. But what I want to reiterate is that when you're threatened with an attack, your body will react. It's just to what degree you can get control of your body sooner, because it's real easy to start saying, oh, I know what's going on, and that's your professional role, saying calm down, everything's fine. In the back, you had a question?
No, I was just wondering what she was saying. I can't really hear.
She was saying it's different if a person doesn't know what's going on. They don't know, they're out of their mind. They don't really know what they're doing, versus the person that really is intent on hurting you and somebody else. She says she reacts differently in those situations, which is good. All right, so when I self-control, what's helpful for me is to just start paying attention to my breathing, and I have a tendency to start talking louder when I'm threatened, because I have a fight response, and I have to tamp that down. I have to control my breathing. I have to look around, see what's going on. My hands. When I first started in the 1970s in behavioral health, there was a big movement for meditation and relaxation, and one of the first exercise I learned was to take your hands and put them in fists, and this was done under hypnosis, I think. But if you look at your hands and feel them, and if you're in a fight situation, you almost automatically ball up your fist. So for me, just opening my hands like this, and then breathing, it makes me feel better. And when you have someone threatening you, and you have fists in like this, it increases the threat level. If your hands are open and facing them, you're less threat. So, 2 good reasons to open your hands. You're showing them that you don't have a weapon, showing them that you're not a threat. Voice, speech. If you have a fright or flight response, your voice tends to get high and squeaky. You want to be able to modulate your voice and bring it to the right point. Body movements, when you're in a threatening situation, no sudden body movements. And if the person's afraid, sometimes they're so afraid they want to hurt you, standing off to the side with your hands open. And not close, as far enough away where they can't hit you with one punch. Exit strategy. See, when you go into a room, and whether the patient's agitated or not, do you know where the door is? And are you sure that the patient's not between you and the door? It's a simple thing, but it's so important. Getting trapped in a room with a patient that is intent on hurting you is scary. And so always know how to get out. Always know your way out. Just kind of, even just when you walk into any room, just think about, I do it at restaurants, I swear. I go in and I go, okay, there's the corner over there, I can see what's, and I go into a door, and I pick my seat based on where I can see people and where the exits are. I don't know. That's just me. Too much time in psychiatric wards. Yeah. So I say disengage when you can no longer be helpful. So if you've got control of yourself, you've measured your breathing, you're talking to the patient, but you've lost, you felt I'm out of control, I'm not, you find yourself screaming at the patient, and like you said earlier, I want to hit him. That's the time to disengage. You need to have one of your team come in and help you. Disengage, because if you're not being helpful, then maybe somebody else can. Okay? Thoughts? Ideas on that? It's hard to say I can't do it, but it's better off in the long run if we live to fight another day. Crisis communication. I just want to touch briefly on crisis communication. So when I say assertive I statements, what I mean is when you use I language, you want to take judgment out of it. You want to say you own the feeling that you're having, and you want to be non-judgmental. Not threatening to the patient, not critical and cynical. We tend to get, sometimes when we're over and over and over with the same patients, we tend to get cynical with them. That's okay in the back room. You go say, hey, this guy, here he is again. But when you're with the patient, we want to be assertive. We want to state what we want in a way that gets them to understand we have to get something done. When you scream at me, I feel scared. Can we please talk to each other in normal tone of voice? Just like that. I mean, it's not always that simple. It takes practice, lots of practice. And I actually have a whole module on assertive communication that I'm developing. And I'll post it on the calendar when we're done. It's great. It's a great module. So self-control, worth repeating. When you're talking to this person, pay attention to your voice. Pay attention to your body gestures. You talk with your hands. If you do, put your hands in your pocket. Well, maybe keep them open. Pay attention to your body movement, gestures. There's a story of a nurse. She comes in the room, and this guy was upset and agitated, and she comes in, and she's shaking a needle like this at the patient. How easy do you think it was to get that shot into that patient? Very hard. We had to chase him around the room. So if you're going to give a shot to a patient, put it in here and keep your hands open and go, okay, come on, we have some medication for you. And I know you guys know all the tricks. Stay in balance. So if a person's sitting like Juana's sitting, and I want to talk to her, I'm going to come up and I'm going to kind of sit down. When you're standing above a person, I know sometimes it's difficult when they're in bed, but balance and level, eye level the same, easier to manage. And now, when I sit in balance, I mean, when I talk about balance, I literally mean knees bent, feet shoulder width apart, and ready to move. When you feel like there could be an attack, be ready to move. Get yourself in a position and know where you're going to go. Okay? Can we find the win-win? So when I say win-win, what does that mean to everybody?
Patient's happy, you're happy.
We're both happy. We're both got what we want or need. We may not get all we want or need, and he or she may not, the patient may not get all they want or need, so we compromise. We meet in the middle and say, right now, this is really important that we give you this medicine. I understand you're afraid or you're in pain, but this is going to help, and this is something the doctor's ordered, and we feel it's going to help you. Short-term problem solving is always a key. Flexibility and creativity. So don't get locked into rules. This is the biggest lesson I ever taught my staff in the 17 years I managed the child unit. they were so into rules when I took over, and you have to follow. This is how we do it. You're going to do it this way. If you don't do it this way, we're going down here. We're marching you out. The rules are important, and under certain circumstances, some things can't be compromised. But be creative and think of how can we meet that? How can we follow that rule in a way that's going to help this guy? Okay. That's what that means. So, crisis communication, what's next? Planning. So, when we talk about planning for safe outcomes, what it means is that as a team, we discuss beforehand, or if we know if we have a patient that's aggressive, we can plan beforehand. You guys don't really do you get a lot of return patients? Yes?
Yes.
So maybe you can plan for that patient that's always been a problem. He's coming in, this so-and-so's coming in again. Let's plan how we're going to handle his or her behavior in a planned way. How are we going to make it safe for him and us? Proactively planning what we're going to do, where we're going to have him, where we're going to put him, how we're going to distract him, and so on. And involve the patient in the planning. Set up expectations of his behavior, and that's always good to talk about it ahead of time. When you do this, we expect you to do this. If you act this way, this is how the whole team has agreed to respond. Anticipate the needs of difficult patients and reach an acceptable agreement beforehand. Reach that common ground before things happen. If you reach a common cause or a win-win and problem solving before the problem occurs, it's easier when it actually happens to say, Bill, don't you remember we agreed that when you go down to CT or wherever, you have to have a nurse or whatever, whatever situation it is. Or you can't have lasagna in the unit. I don't know. Whatever the case may be. So once you reach an agreement on an acceptable behavior and the plan and everybody's on board, it's important that everyone on the team who's going to care for the patient knows the plan. Or everyone that's going to deal with an aggressive patient knows how they're going to respond. Everybody has a role. Everyone uses the same plan. When I talk about creativity within the plan that we had established. Because consistency and calm wins the day. Patients that are aggressive and patients that act out, and not necessarily violence, but patients that create uproar, are professional at splitting you. They will find out. What's your name? Wendy? Wendy? Juana said, I can go outside and smoke. Juana said I could have lasagna. What the hell's wrong with you, Wendy? Don't you know Juana's the manager? She said I could have lasagna. You need to go heat it up right now. So if Juana doesn't tell Wendy, she's thinking, well, what the hell is Juana doing? Then if you find yourself arguing with each other, if you find yourselves in an intense argument over a patient with each other, the doctors, if you guys are bickering back and forth, that patient's splitting you, and they're good at it, and sometimes we don't see it until it's too late. And once we do see it, we have to back up. We have to have a concrete, consistent plan that everybody knows, and everybody has to do the same thing. Repeat it over and over. This is your plan. This is how it goes. Shift to shift, day after day. So, calm and consistent wins the day. Okay. See this? Remember I talked about self-control? First of all, is anybody in this room owned a Honda CR-V? No? Good. This is my car. Right? So I get off. I worked 8.5 hours. I get off. I go out to the parking lot and I look at this and I'm going, what the hell? So I had to institute a self-control plan because I really wanted to take my aggression out on that car because the person wasn't there. So I said, okay, I'll just write a note, right? I get my briefcase and I get out a piece of paper, no pen in my briefcase. And now there's always a pen in my briefcase. So every day in life, not just with patient care, we encounter things and we have to gauge our level of response, and we have to control ourselves to not become aggressive. So what I'm saying is all human beings have a potential to be aggressive. And when we recognize that and say, people only result to aggression when they can't get what they need any other way, and they can't communicate any other way. So it's a form of communication and meeting unmet needs that is not functional. It's not it's not socially acceptable, but it happens. So if I'd have kicked this car, would I have been within my rights? No. So I had to crawl in through the other side. I mean, literally. It's a Prius, right? And I'm not a small guy. I had to crawl over the seat into the deck. And there's just no way. My 2-year-old granddaughter couldn't have gotten this car. Anyway. So thoughts or questions? Anybody? Something else I didn't touch on, or you want? I mean, this is kind of the overview, but we have time to ask questions. Yes.
Every once in a while, I see a patient respond positively to, like, some of the nurses and some of the doctors will speak to them like, almost like a parent. You need to calm down, like sternly, you know. And sometimes that helps, and sometimes it doesn't. So it's like, sometimes, oh, now please hold still, you know, we're only trying to help you. I mean, that only takes you so far. But
Well, I mean, and everybody has their own techniques, and if they raise their voice and say you and become parental, if they assume a parental role, there's some aggression in that.
Yeah,
okay?
That's what I'm saying. They're like taking more.
Now that may work 9 times out of 10, but there's going to be that one patient that hears that and reacts. Aggression can breed aggression, not always, but assertiveness.
Well, you would tell according what type of patient you're dealing with. Some of the patient is work, some you won't, but by dealing with the patient, you know what other type of response you need to have to address that person.
Being flexible with each individual patient. Yes.
I feel like we're missing an area, at least because we all work in the trauma bay and with the trauma patients that we work with. I feel like I get a lot of aggressive behavior towards me in patients that I'm worried about them hurting themselves.
Okay.
And so my response is like, how do I protect them from hurting themselves? And a lot of times it'll be people that are like demented, like you talked about, or maybe it's a language barrier or something like that. So there's a miscommunication. Sometimes it's language related, but sometimes it's also just physical, like they have a head injury or something like that, or they have a baseline thing. And so it's not so much that they're looking at their nurse and trying to hurt me. It's more of they're trying to get up, they're trying to get out, and I need to keep them in the bed to keep them safe.
Right.
And so that's where this aggressive interaction can take place.
So they're not really consciously aware of you, or they're not cognitively aware that what's going on?
Right. They don't, or they just don't understand the situation that I'm their nurse. I'm
Right.
going to take care of them if they see me as a threat or something.
So that's somewhat different, because if you can't engage that person in a productive conversation, communication, then that is different.
And I feel like I deal with that almost more than I deal with more of an, maybe not more,
Well,
but I feel
what
like an actual aggressive behavior is easier to deal with because then I can call in the resources like you were talking about.
Right,
or then
right.
we have a plan like, we can restrain them and put them down and sedate them and all that kind of stuff.
So I think you guys are the experts at when a person's not cognitively aware or in the situation. You are more expert at managing that and keeping that person safe than me. My gig is I'm able to talk to this person and they understand what's going on. But that's a totally different situation, and you need to take charge of that person to keep them safe. Absolutely. The only other scenario that's similar to that I can understand is a trauma response or a PTSD response that we see in behavioral health all the time. Patients that have been assaulted, attacked, sexually raped, molested. And when they have PTSD and they have a trauma response, They literally have a dissociative episode where they are not present in that interaction, and it's very important to back away and not engage that person because they don't hear you, they don't know what's going on, and in touching them or trying to hold them makes it worse. So if it's not possible, that person has to be restrained in that situation. In our situation, we kind of let them stay in a room. We try not to touch them, but I know that episode where they're not there. When you know they're not there, the lights are on, nobody's home, you have to change your response. Does that make sense? Yes?
But even if we get a patient into the trauma bay, they may not have PTSD, they may not comprehend everything we're doing, but they're still aggressive towards the staff. It's our responsibility to still take care of them and do their assessment. How do you think we should go about doing that? Because a lot of times we just end up sedating them and intubating them to get our work done, to be quite honest with you. But is there any other techniques you recommend to help these patients calm down so we don't have to sedate them and intubate them and then they turn out they have no injuries and then...
I think going back over what we're talking, go back over to communicating, staying calm, trying to find out what they need, getting down to the bottom of what's bugging them, what do they want from you.
Well, a lot of them just want to get out.
Right. They
That's the bottom line. They don't want to be there.
They
Right.
don't feel that they need to be there. We're cutting their clothes off. There's 10 people standing over them. We don't have a means to sit down at their level and speak to them like that.
Right.
We don't have chairs to sit down. They're laying on a table, no side rails. You can't step 10 steps away from them without them hopping off the table or falling.
I think bringing the noise level down helps. Everyone needs to be quiet, in the room.
So any other ideas on how that we could calm that down?
Well, this is not something like, if you don't stop, you're gonna get a tube down your throat.
That's like the needle, the nurse run.
In charge of what everybody else is saying to them. There's a lot of other
and you have to, and there's things that you have to do and you can't get done, and if you don't get them done, if he does have that injury, so maybe medications is the best choice. Maybe not necessarily intubation, but maybe meds to calm that situation down. Yes.
Is it not forcing them to do something that they don't want to do, so if you want to do it today during different minutes? Exactly what the beginning of the conversation was.
Yeah, it is. If it's in certain situations, if it's an emergent and you document it was emergent that we calm this person down so that we can treat whatever that is. If you document it's emergent, it's okay. You can give medications. Yes.
I'm just saying, we're doing this for a lot of closed injury. The reason why they don't have the trauma. So if you document that we had to intubate them because if anyone had CT without them being sedated, you document that because we're ruling out a head injury. I think they're covered.
Yeah.
It seems like a lot of lately I've had the dogs let them go too, like if they're a GC for 15, even if they're smelling of alcohol, like we had a guy who picked up and he was completely irrational. He did smell of alcohol, but he was, I think it was Dr. Allison, questioned it, and he was totally, just didn't want to be here to that, so she let him go, from the table, We used to sort of always, press that issue.
Yeah, we as an organization, we really try to talk patients into not leaving throughout the system, not just in trauma or ED, up on the floors. Patients do have free will, and this is a discussion that I actually have a case study that I'm developing just something similar to this. A patient got TPA in the ED, went up to CCU and did not want to stay, yelling at nurses, and the doctor said, you got to stay. They explained everything to him, and these are the risks, here's your risks. But they end up letting him go, but it was quite a scene before. So this is a healthy discussion, and it's a good discussion to have, and I'll recommend that. Ethics or risk. Yeah. Other thoughts, ideas? So I thank you for your time. And now I'm also going to be developing a 4-hour workshop that goes into greater detail of case studies, role plays on communication and then actual self-protection. And that is going to be available probably late this year, early next year. And it'll be on the EDR calendar. It's going to be called BERT. Behavioral Emergency Response Training. And because we had Art, Bart, Fart, and now we're going to have BERT. And it's going to be comprehensive. It's 4 hours. You'll have contact hours. I'm probably not going to charge anything for it. Probably have food. Anybody? Any other thoughts, ideas? If you have something, you have a patient, and you think you want me to come up, page me. I'll come up and try to help. B. Vandersall. Just type in Vandersall, VANDER. I don't have any cards. I'll send an email to Juan, and they can post it out. Thanks for your time, guys.
Thank you.